Hello, everybody. Well, looks like we've done this a few times before. I can't remember. I've kind of lost count on how many Henry Schein webinars we've done, but doing something just a little bit different. We've done implant, or I've done implant webinars with you guys before, but we've pretty much mostly focused on just routine dental implants and restorative. So we're going to actually focus on smile zone mistakes specifically today. So let's see if I can get my screen shared. All right. So hopefully you guys can see my screen. Mickey, text me if you can't, but let's go. Today we'll take about an hour just because I don't have obviously all weekend long to go over like immediate implants and aesthetic zone stuff, but we do have an hour to go over at least a few mistakes that I commonly see. So we're going to talk about smile zone mistakes you don't want to make. And these are the type of mistakes to where you're like thinking about them at night. You can't believe that you just did what you did, and they'll haunt you forever. And I don't want that to happen to anybody. As you guys know, one of my biggest ways to engage is on Instagram. So I've got two accounts. One is david.wong.dds. The other one is Plaque China. Plaque China is obviously the more bloodier surgical account. David.wong.dds is my more personal account. So with that, I want to start off with a case that I was recently referred from a friend of mine, and he got referred to restore this case from another specialist. So here's the harsh reality of implant aesthetics. So this young man shows up to my buddy's office, and this is how he looks. And his statement to my friend is, "Hey, I'm ready to have my implant restored." And when you look at this as a dentist, you're like, "Oh my gosh, what what am I going to do here?" Clearly, he's not ready. And lo and behold, this is actually just the healing abutment. But before this, he actually did have a dentist restore his implant. And I'll show you that here in a second. But what he looks like right now is he's got this healing abutment on, and as you can see from his CAT scan, he's got no facial plate. The implant's too far facial, uh, and that's why you can kind of see the implant through the tissue, and you can tell that there's not a whole lot of bone around the implant. The text I get from my friend is, "Hey, I have a patient that I'm trying to restore his central implant. College soccer player got kicked in the face and knocked it out. Lab had sent me a titanium and gold abutment. Looks terrible. The crown is too long and had to add pink porcelain. He says, I hate this all so far. Will you look at these photos and tell me if you think a tissue graft would help this kid?" So this is what the kid actually looked like when he had his crown. And as you can imagine, this is a college soccer player, and this is how he looks, with his front tooth. So nothing that any of us would probably be super proud to show our other patients or anybody else. So today's goals, what I want to talk about are pre-extraction socket evaluation, uh, things that I look at. We're going to talk about classifications of different sockets. I want to show you guys how to assess the bone and the soft tissue conditions for an immediate implant placement because we're going to be talking more about immediate implants today. We're going to talk about common techniques for successful implant placement. How do you get your implant in the right spot when you just have this big socket staring at you? We're going to talk about immediate implant do's and don'ts, and specifically, how the rules change a little bit for the aesthetic zone. So this is all going to run based on my patient, Leanna, here. And we're going to go and introduce different concepts utilizing Leanna's case from start to finish, and then we'll end with an easier case that I feel like would be appropriate for everybody. So this is Leanna, and you can't tell from this photo, but she has a hopeless tooth. You can't tell which one it is until you take an X-ray. Now we're taking this X-ray, and you can see that we've got a horizontal root fracture right there on tooth number 9. Unfortunately, she looks great, right? Or fortunately, she looks great. But unfortunately for us, she doesn't know or isn't aware of how grave her situation is. So in a situation like this, what commonly happens is obviously you get the prognosis of that tooth really easily. You have a non-restorable horizontal root fracture. You're going to take the tooth out as atraumatically as possible using your, fancy instruments like your periotomes, and we eventually get the tooth out. Once the tooth is out, you evaluate your socket and you're like, what's next? right? And that's kind of your typical emergency visit. That's what happens a lot of times in our dental offices. But the question that we commonly have is, do I put an implant in the socket right now, or do I just graft it? So going back to one of my old mentors, Dr. Carl Misch, he used to say, if you had all the money in the world, all the time in the world, and all the talent in the world, what would you do? And this is a good time to ask that question, right? Like, what if I was, if I was this patient, or if this patient was my mother or sister or whatever, what would I do for her? So what I want to talk about first is, before we jump and start taking teeth out and start, plugging, sockets with implants, we really need to look at the patient and the site specifically, before we decide, whether or not we even want to take this case on. Because just because we know what to do with a hopeless tooth and we have the skills to take out the tooth does not necessarily mean we know how to adequately replace the tooth. So I want to start off by, for all the people who are kind of newcomers to dental implants, or maybe you haven't done a whole lot of front tooth implants, let's help you choose the right patient for you. So one of the things we want to look at is the importance of tooth morphology. And all that means is the size and the shape of the tooth matters when it comes to dental implants. So you have two choices here. You have the patient on the left who has short, square teeth, and you have the patient on the right who has long, tapered teeth or long, triangular shaped teeth. Which patient do you want to treat? And this is for aesthetics. So if I were you, I would pick the patient on the left. We want this short square tooth because short square teeth people have more stable papilla. They typically have thicker tissue. And shorter square teeth, they tend to have less shrinkage of the tissue and respond better to surgery. So that's why you would pick a short square tooth person. The second criteria is pretty easy. You either have a high smile line or you have a low smile line. So hopefully everybody sitting in their chair right now is going, I want to treat the person with a low smile line. That would make the most sense to me as well. The problem is that the person with a low smile line, usually it's a man over a woman, and it only affects about 20% of the population. So we don't get to work on the low smile line person that often. One thing that we need to talk about though is the papilla. So a lot of times when we talk about low versus high smile lines, we're strictly talking about whether or not the lip covers up, the zenith of this gingival margin, and that's not always how we should look at high or low smile lines. I love this paper by Stephen Chu where he talks about the papilla, and he says that the papilla show about 87 to 100% of the time when a patient smiles. So it's not necessarily that the lip doesn't cover or show the gum line, it's whether or not it shows the papilla. So as you can see here, but before and after, the patient still has a classically low lip line, but look at that middle papilla. Clearly lost the papilla, so this patient is not going to be aesthetically happy. So the next criteria that we have to look at as far as smiles go is the periodontal phenotype. There's only two types of phenotypes that you can choose from. It's either thick or it's thin. So in a situation like this, the thick one is on the left, the thin one is on the right. As you can see, the person on the right, you can see the outline of their roots. They have very sharp papilla. They have long tapered teeth. Go figure. So the reason why you want to pick the thicker phenotype here is, once again, the importance of understanding that patients are getting ready to have surgery by you, and you want their tissues to be as stable as possible. You don't want them moving up or down or shrinking or swelling. And that is less likely to happen with a thicker phenotype. So you want the thicker phenotype for more stability and a better response to all your surgical and restorative procedures. Last thing we've got to look at is a occlusion and tooth alignment. I cannot tell you how many times when I was first starting my practice, patients would come in, they wanted an implant, and I would be so excited that I would just put the implant in. And then later on, they would ask, hey, what about braces? How do you feel about my teeth? Should I get them straightened? Or whatever. And I would be like, oh my gosh, we should have asked that question before we ever got started, because now you're stuck with that implant position. So let's go back to Leanna, and you have her situation. She does have a low smile line. She doesn't like to smile that much, but even you can tell here, even though she just kind of half smiles or half grins, you can still see the tip of her papilla between her front teeth. It's barely, but you can still see it. You would definitely notice it if it was gone. So going back to her radiograph, you can see that we have that horizontal root fracture and the tooth is out now. So what else do you need to know? Well, what I'd like to know is actually when would have been a good time to plan your procedures? And this is where I like to teach, proper planning because and thorough planning because a lot of times we get suckered into taking out a tooth because a patient's in pain or whatever, and we take out the tooth and then we ask the questions later. And sometimes that can be too late, as you can see here. These are immediate implants that have been placed by, some of my friends and colleagues. And what you can see here is the most common mistakes that I'm going to talk about apply to all four of these cases. Here you can see implants that are placed too far facial, they're angled, they're too high, the gum tissue is too thin. There's a lot of problems going on here, and I want to go through these and hopefully help you all avoid them. So when it comes to goal setting, when it comes to looking at the final product of dental implant aesthetics, I like to just very, very briefly review the pink aesthetic score. Guys can look at this on your own time, but we look at 7 different criteria when it comes to proper pink aesthetics, soft tissue around the implant. We want to make sure that we have proper mesial papilla height and width. Same thing with the distal papilla. We want to make sure that we have even soft tissue levels. If we're talking about central incisors, we would love those gum lines to be even. We want to have a proper contour. So we want similar and elliptical shape at the gingival margin. We want to have, obviously, preserve the bone. And we want good soft tissue, color, and texture. Okay. The other information that you need, in addition to knowing what the final outcome should look like, we've got to look at a radiograph, right? So here's our 2D X-ray. And from the two-dimensional radiograph, which we all should be taking at the very bare minimum is a 2D radiograph, obviously, we want to look at the patient's periodontal condition. We're going to talk about answering the question, will there be a papilla when we're done? We want to address any periapical pathology that we can see. We want to look at the bone apical to the root, and we want to look at root proximity. How close together are the roots? So let's go through those one by one. So one of the things we have to look at before we take out a tooth is the periodontal condition, and is there inflammation under control? So as an example, with Leanna, you can see she's got pretty good interproximal bone levels. She does have some bone loss between, number 9 and number 10, but for the most part, she's in pretty decent shape. She does have a little bit of bone loss though. But contrast that to, this case here, where you've got just a ton of bone loss between the lateral and the central. When you look at something like that, you're like, man, for sure you're about to lose your papilla. So, which brings us to our next question is, will there be a papilla when we're done? So one of these things, a lot of you guys know this paper from Dr. Dennis Tarnow back in 1992, but it's been confirmed a few times as well, and with similar numbers, is what you do is you look at the distance from the crest of the bone to the contact point between two teeth, okay? The contact point is what we're looking at, not the CEJ. You're looking at the distance from the bone to the contact point. And when that distance is 5 millimeters or less, we have discovered that you get the papilla returns or preserves itself almost 100% of the time. When you get to 6 millimeters, that gets almost cut in half to 56% of the time. And once you get that distance to 7 millimeters or more, then the papilla are only present about 27% of the time. So that's just a really important number that you guys may want to keep in mind. Now, what about periapical pathology? Now, in the old days, whenever I first graduated school back in 2000, 25 years ago, I can't believe it. Our instructors would say if you have a tooth that's got a periapical pathology, you don't want to put in an immediate implant. It was actually contraindicated. So it's a pretty controversial topic. But one of the papers that I've recently looked at, this is from 2024, just last year, and they talked about looking at all these studies with certain criteria. They only ended up with 10 studies, but what they could tell was as long as you can keep the site clean and your implant stable, then it is a feasible option to place an immediate implant in a socket that had a previous periapical pathology. So do it at your own risk, but make sure that you clean it out really well and make sure that your implant is stable. One of the other things I told you to look at on your 2D x-ray is ask yourself, is there any bone apical to the root? Now, this is important because a lot of times, the majority of the time, the implant size that you'll be selecting is going to be significantly skinnier than the socket. So how we get our initial stability with our implant is utilizing the bone apical to the root apex. So ideally, you want 3 millimeters or more of bone apical to the tip of the root so that you can get very good primary stability. What is adequate stability? Adequate stability typically is defined as 32 to 35 Newton centimeters. If you were to look at all the studies, 32 to 35 Newton centimeters is considered adequate stability for a single tooth. Lastly, we want to look at how close together are the roots. And I think a lot of times people don't look at this. So this is Leanna. She's got pretty good root proximity. We're not, in real danger of hitting a tooth or anything like that. But I always remind people the final outcome is when you put your implant in, you should be 1.5 to 2 millimeters away from the adjacent teeth. And that's pretty critical. Now, why is that critical? Well, if you have a case like this, for example, you have tooth number 9 and you've got a horizontal root fracture, you definitely don't want to take the tooth out and do one of these numbers, right? Where you hit a tooth. And you can see this on a CBCT where you hit another tooth. That is not something you want to do, right? If you do this, this is like, oh my God, I'm not going to sleep. I'm going to get sued, blah, 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 blah. You worry about these types of cases, okay? This is actually one of the patients that I've had to treat before that this happened to. So how are we looking so far with Leanna based on a 2D X-ray? So far, I'll go backwards here. Got no periodontal disease that we have to worry about. We have pretty good bone apical to the root, pretty decent root proximity. We have good height or good distance from the crest of the bone to the contact point. No periapical pathology. So right now we're looking pretty good. What else do we need to know? Well, we haven't looked at anything in 3D yet. And we need to look at things in 3D because we have to figure out what kind of a socket we have. So in general, when we're talking about implants, we look at sockets and we classify them into, there's different classification systems, but if you want to keep things simple, this is Elion's classification, and there's 3 types of sockets: type 1, type 2, and type 3. I'll go over all those. Type 1 sockets, you have good soft tissue and you have a facial plate present. That's a type 1 socket. That's what you want. Type 2 socket, this is what you don't want. You have good soft tissue, but you don't have a facial plate or it's a compromised facial plate. Type 3, also terrible. You have no soft tissue present and you have no facial plate. Now, I like this diagram because I know what to do with type 1s. I can do whatever I want. I can do an immediate implant. I can do a delayed implant, staged, whatever. Type 3 I like as well because I know what to do there. We have no tissue and we have no bone. So that means I have to rebuild everything. That's not a problem. Type 2 is where everybody gets into trouble. It looks nice because we have great soft tissue, but we have a compromised facial plate, which makes us want to do things that we don't want to do. So we know better, but we sometimes do the opposite with these type 2 cases. And it's just because the tooth looks so good and healthy that we can't resist it, even though the bone situation's not good. So with type 1, here you go. Here you have great soft tissue, great bone. Type 2, the tooth looks great, but on that CBCT, you can tell that we don't have much of a facial plate, if any. Type 3 is easy. Tissue's terrible. The bone's terrible. Are there other types of sockets? Like I said, there's lots of different classification systems. This is from my friend, Dr. Howie Gluckman out of South Africa. He's got, five, six categories actually. Because there's a 2A and a 2B, but here you can see there's different types of sockets as well. The root position can vary, from the buccal side of the of the socket or the middle, and then of course apical to that. Look at class 5. The bone, hour is like an hourglass to where you've got nothing, apical to the root. So this classification system is very helpful at all. But the bottom line here is you don't want to place an immediate implant without a CBCT. So if you just go through here, I've just taken the liberty of just collecting a lot of CBCTs to show you guys, the different root positions and the different sizes and shapes of the alveolar process of various teeth here. So these are all ones you look at, like the second one looks like a pretty easy immediate implant. You know, the fourth one here, terrible, right? That does not look fun at all. Lateral incisors, same thing. They're small teeth to begin with, but they can pose some problems. And canines also pose some problems as well, because what happens with canine teeth when you try to take them out atraumatically? A lot of times their facial plates, like all three of these here, are so thin that you break off the facial plate. So if you're have done like what I've done many times in the past, break off a facial plate, you got to know how to manage that. And sometimes that's not with an immediate implant. Premolars, if you're starting off, I love premolars for our first immediate implants, especially the second premolars on the upper. Nice straight roots a lot of times, single rooted teeth a lot of times. So those are nice, nice ones to handle. The upper first premolar, that can be tricky because it's a two-rooted tooth, and that facial root sometimes can be hard to get out without breaking the facial plate. Also, they're hard to implant sometimes because the canine root often is angled towards that socket of an upper first premolar. Now, the treatment planning dilemma we'll have when you take out teeth is like prime example here. This is a friend of mine. I had to take out her tooth. And before we took out the tooth, I did this plan for her, and you could see what the dilemma is. She's got great bone at the apex and towards the lingual. So I can take the tooth out and place the implant where the bone is. But the problem is that it's going to exit facial. So she'll have to have an angled abutment and cement the crown if that's what she wants to do. Or I can put the implant where I would love to put it, which would be slightly lingual to the incisal edge so that we can have a nice screw retained crown, which is what she wants. But the problem there is the apex of it is sticking out the facial plate. And also, that's also where her tooth is. So we may not have very good primary stability if we try an immediate implant. So this is the treatment planning dilemma that we run into. So what would you do here? For me, if I was this patient, I would just do a staged approach. Take the implant, take the tooth out, grow the bone where I need it. And that way we can put the implant in where we want to. If you just want speed and speed is your thing, you can do option one over here, and just place the implant immediately, knowing that it's too facial and things may look kind of goofy. So we talked about Leanna. I think she's relatively, low risk. Looking at her soft tissue, she has kind of tiny papilla anyway, so they're not the big, tall, skinny papilla that I worry about. We already talked about her, no periapical pathology, pretty decent interproximal bone height, good soft tissue. Um, Everything's looking good so far. Now, if I want to put an immediate implant on Leanna, where does the immediate implant go? So I want to introduce you guys to the 3-2 rule. You guys probably, if you've heard me speak, you've heard me talk about this. We have a 3-2 rule with anterior implant dentistry. And I didn't make it up. It's already been published, and it's at this point it's a 12-year-old paper. But what the 3-2 rule is that when you place your implant, you want the implant to be 3 millimeters apical to the gum lines of the adjacent teeth. Okay. And you want it 2 millimeters towards the lingual, meaning that you want 2 millimeters of tissue to the facial of your implant. The reason that's important is because we've all seen these implants placed where once you get the final restorations on, the teeth and the tissue look kind of gray or dark, kind of like you see here. The reason that happens is because the implants aren't placed deep enough into the lingual enough to mask the uh, the metal underneath the hard and soft tissue. So when we look at Leanna, this is where the implant goes. As you can see on the top CBCT slice, it goes 2 millimeters to the lingual so that we have a cingulum emergence for a screw retained crown. But you also want enough hard and soft tissue to the facial to mask any gray or any dark colored tissue. It's 3 millimeters deep. So when we look at the gingival margins, it's 3 millimeters apical to the gingival margins, not the CEJs. It's the gingival margins. Okay. So I like Leanna here. I like her for an immediate implant. I think she's a relatively low risk for the reasons that I just outlined previously. Talking about perio, endo, uh, smile design, everything looks really good for me. So this answers the question that Dr. Mish always asked me as well, was there's a difference between could and should. So just because you could, should you? So I think in this situation with Leanna, she's low risk enough to where I like the aesthetic risk. I like her periodontally, endodontically, love the facial plate and the implant position. I think we can nail that pretty easily. So how do we go about doing an immediate implant? So once again, we started off with an implant disaster, and I like to remind everybody that immediate implants can be disastrous, right? If you guys have seen my implant complications lecture with Henry Schein as well, you'll know this patient Haley, and how we fixed her was pretty challenging. So we want to avoid doing stuff like this to Haley. So when you don't plan properly and more importantly don't execute properly, you can really leave your patient with a pretty, unhappy smile, even though she's smiling. So even with proper implant placement, this is Haley again. You can show me these x-rays all that you want to, and we can show our patients these x-rays all that we want, showing the implant placed perfectly between the two teeth and right in the middle of the bone. All they're going to care about is that the crown or the tooth does not look like it's supposed to. So we don't want to disappoint our patients. We don't want to disappoint ourselves, because I definitely think we can all do better than this. So I ask myself questions. Why immediate implants then? If all these bad things can happen, why would we even do them? Well, a lot of times we do immediate implants because it's saves chair time, right? The patient can come in, we can take out their existing tooth and they can leave the same day with the tooth. We're trying to save patients money. We want to save them pain, obviously. And it seems simpler because you're just taking out a conical shaped tooth and you're replacing that same conical shaped tooth with a conical shaped implant. And then we also like to use the word better, that it preserves the hard, soft tissue. We have better survival rates. It lasts longer. It looks better, and patients are happier. That's kind of what we tell our patients on why they should do an immediate implant. But I question all that because if you look at this article from Gamarena, Marcus Blatt, friend of ours as well, we can challenge, whether or not things are actually faster or cheaper or better. Because if you look at this article and just all the steps that are involved with doing an immediate implant, there is a lot of things that are not chair time related, like all your pre-op planning. Um, you're on your computer, you're talking to the lab. But even once you get to it, we're not talking about a very simple, set of procedures. You have to have an atraumatic extraction, meaning you can't be breaking off the facial plate. You have to precisely, drill your osteotomy properly so that your implant doesn't wiggle around when you put it in. You have to be familiar with bone grafting materials and how they operate. A lot of times I recommend, especially for my beginners, to do their aesthetic cases guided. We got to have abutment selection. You have to figure out how to provisionalize. If you want to do it chair side, do you want to do lab fabricated, or do you want to just do a custom healing abutment? And then, of course, there's soft tissue grafting on top of all this. So, when you add up all these things that you have to do an immediate implant, I do question whether or not we actually save time. We certainly may save our patient time, but I don't know about our time. Um, does it save the patient money? This is a big one. So when I talk to a lot of my doctor friends, a lot of times I've been shocked actually that a lot of them charge less for an immediate implant. I charge more. And the reason I do is because of Dr. Carl Misch. He said if I'm taking more risk and you have a higher risk of complications, then you should pay more, and it shouldn't cost less. Where in our society do we save time, convenience, and less pain, but also pay less? That doesn't usually make any sense with anything else. So I don't think it saves time or money. It definitely saves the patient pain in regards to the number of procedures that they have to go through. So I could say it's there. Better, I would say immediate implants definitely look better when they go right, but nothing looks worse than an immediate implant when it goes wrong. So I always tell people try it. Case selection with these immediate implants is the biggest thing. You want to make sure you pick a case that even if everything goes wrong, you could still go backwards and do a staged approach and still be fine. Case in point, right here. We have a patient, things haven't gone great, but now we're still at a single site, tooth number 8. You can just graft the socket. You can place your your staged implant 3 months after your extraction, and you can still come back and restore it, and it's still going to look dynamite. So if we really break it down, why do we do immediate implants? And a lot of times it breaks down to two simple answers. Everyone else is doing it, and I don't want to hear my patients bitching about how long it takes. That's usually what it comes down to. Trying to keep up with the Joneses, and also just not wanting to hear from patients. So, with that being said, let's do some immediate implants. So, one of the things that we have to talk about is we don't have all the time in the world to talk about all the extraction techniques and what do you do with the socket. But it just suffice to say that there are some things that we can do to manipulate the critical factors that I talked about earlier. We can use orthodontics to improve our interproximal height of bone for our patients who have a little bit of bone loss or periodontal disease. We have ways that once we place the implant towards the lingual and 3 millimeters apical in that 3-2 rule, we have ways to do that. We have ways to graft the gap with, bones, bone grafts and membranes. And then, of course, we have these other things too, like the partial extraction therapy, where you just take out the majority of the root and leave that facial root shield in place. So there are lots of things that we could talk about that we won't get to today. Once the implant's in place, earlier I mentioned, needing soft tissue grafting. We're going to talk about the dual zone today, which is hard and soft tissue. Hard tissue grafting with the addition of a membrane and a provisional restoration. And then, of course, sometimes we have to abort mission, and the patient does not leave with the tooth, but they leave with a custom healing abutment, like you see here. Finally, staged approaches. Sometimes, docs will take our course and they're like, when I check in on them a few months later, they're like, I still haven't done an immediate implant. I'm just still doing socket grafts and a little minor, soft tissue grafting. I'm like, that is fine. You can still do a great job doing ridge preservations and socket seal grafts and, staged approaches and guided implants. If you just stick to these 4 things, you can still do a wonderful job for your patients aesthetically. So when we talk about how perfect the case Leanna is, we still have to ask ourselves, how do you take out the tooth atraumatically? Do we place an implant at the same time or not? We talked about the implant position. We talked about the need to graft. You always graft the gap. Talk about that. And then one of the other major questions, especially for patients, is whether or not you provisionalize, because they want to know if they're leaving with a tooth that day. And then soft tissue addition or not. So we still have some questions that we talk about. But when patients come into me, and this happens all the time, patients have come in with, all bloodied up with a broken tooth in their hand. What do I do? So it's going to look like a huge list of things that I do, but once you get used to it, it goes by pretty fast. So when they come in with their broken tooth, we still do a real quick exam, periodontal screening, radiograph, and CBCT. The IO scans, they don't take very long. Now, one thing I'm not doing in my office right now is making our own guides. So you'll see that I do a lot of free-handed, immediate implants. But for those of you who have patients who have hopeless teeth, but they have time for you to send off for a guide, you can get one back within a few days. It's not that hard. The hardest part for me as a specialist is planning the provisional. And then, of course, you have to tell your patient what you're going to do, because patients want it all a lot of times until they get, the price tag sometimes. And they're like, whoa, I didn't know it was going to cost that much. And so sometimes they, especially in our office in Tulsa, Oklahoma, they will opt to stage their treatment for cost purposes. Once the patient's scheduled, we'll do the surgical planning with a lab, because I don't do my own surgical guides. We schedule an online meeting. For me, I do online meetings every single Monday. And then that means that our surgical guides will come in by the next Monday pretty easily. I'm pretty bad at restorative dentistry, so a lot of times I'll have the lab make me a provisional, so I don't have to do it. Uh, when they come back, schedule the surgery scheduled. We'll take out the tooth. Flaplessly is better, but as soon as you go more towards the back of the tooth, I'll tend to flap them sometimes so I can see more. Osteotomy prep is critical. We got to make sure that we can avoid placing implants that are too far to the facial or angled facially. And then I love guided implant placement, graft the gap, augment the soft tissue as needed, and then you deliver your provisional. So um, the reason that we check into just the occlusion, because once again, I learned from my own mistakes. I've had plenty of times where I've delivered a beautiful provisional only to discover that the patient's got like 100% overjet and they grind and clench their teeth. And then I'm like having to reduce, the provisional and to where it's not even recognizable sometimes. So the biggest tip that I have for this workflow is that don't be afraid to abort the mission. That's what I think gets people into more trouble than anything, is that they get a lot of pride and a lot of ego, that goes into this. Like we promise the patient that, hey, I'm going to come in and put on my cape and save you. Don't worry about your broken tooth. You're going to leave here better than when you came in. And we get, towards the middle or the end of the procedure, and we're like, things aren't looking so good. And then you decide to just keep going anyway, because we've already, talked ourselves up. So don't be afraid to abort the mission if you need to. So we've seen these radiographs on Leanna. So at this point, this is our plan. I want to put a tapered, aggressively threaded implant, hugging more of the lingual plate. I want that 2 millimeter gap to the facial. I want to make sure that we come out of the cingulum, so that we can have a nice screw retained provisional and final restoration. So when you see this plan, sometimes it looks funny on the plan. You're like, you look at where the implant is, and it's not lined up to the other teeth. It should be more to the palate. So we do an atraumatic extraction. Atraumatic, just by definition nowadays, just means don't break the facial plate and don't tear up the soft tissue. So a lot of times I'll start off with a number 15 blade, and then just use my periotomes, as you can see here, to gently uh, loosen and luxate the tooth and then properly elevate it out. Now you can see that we have papilla intact. We have a nice facial plate that's intact. My surgical guide makes it super easy. This surgical guide comes from Vulcan Custom Dental through BioHorizons. And it's just a nice way to place the implant so I don't have to use my brain too much. I used my brain while the patient was out of the, was already gone. After hours, I use my brain. By the time it comes time for surgery, I don't want to use my brain anymore. I just want to just put the implant in. Implant size selection, didn't really talk about this, but a lot of times people put in implants that are too fat or too wide. The BioHorizons 3.8 or 4.2 millimeter diameter is all you need for a central incisor. So if you're using a different brand, that's fine, but use something in the high threes, the low fours for your central incisors. If you get too big, and people go too big a lot of times because that's how they get their primary stability, that's bad. You don't want to do that. You want a nice, standard sized or even narrower implant so that you have room for hard and soft tissue and room for the restorative treatment. Here we got 50 Newton centimeters of torque, which is great. I told you the average is 32 to 35. Here we have a gap that we're going to graft with. What I'm using here is mineralized cortical bone. You can use anything though. If you want to use cancellous bone or cortico-cancellous bone, it doesn't really matter. But this is a prefabricated provisional from Vulcan as well. See how nice this is compared to what I would be delivering. Um, the reason we also use Vulcan, and if you choose to use a different lab, great. Just make sure that they understand that the neck of the provisional should be concave. Okay, we want to make room for that hard and soft tissue to grow. We employ a technique called dual zone grafting, and all that means is that we're going to place our bone graft around the implant to fill the gap. And then here's how I like to place the membrane. I'll just cut a square out and then cut a little slit in it and slide the abutment screw on. And I just screw it into place. This article from Dr. Chu and company was published in 2012. So just take a picture of this and look it up. I believe it's a free article, free access. But once you screw this into place, as you can see here, you just tuck the edges of the membrane um, around the implant site, and that's it. Okay. Safety provisional. I usually just hand tighten it. You can torque it down if you want to, but I usually just hand tighten it. And then we adjust the occlusion to where she's not biting on it. And I check the protrusive and excursive movements as well to make sure that she's not hitting on that tooth. At 2 weeks, this is why we love immediate implants. That preserves everything really, really well and looks better than when she came in. We ran into a little bit of a hiccup with the first crown. It was just a little shade was just a little bit off. The second one was also a little bit off, but at this point, Leanna was like, "Nah, forget it. I'm pretty happy," which she was, and she looked great. I always remind people these photos are like you have a black background, it's all blown up, so it makes everything look worse than it is. But radiographically, we've got bone all the way up to the neck of the implant, and this is her half smile again. You can once again see that papilla. It's important that we preserve that papilla with these immediate implants. This is her. I took a CBCT just for kicks and giggles, and you can see we've got that 2 millimeters of bone to the facial aspect, and it's 3 millimeters deep as I promised. So a reminder here is that immediate implants, once again, are not the only way for implants to look good. So sometimes when you get, I have a personal rule, which is no facial plate, no implant. And all that means is when you take that tooth out and there's no facial plate, and I tell patients this before I even start, if I take this tooth out and we have no facial bone, we can't do an implant that day. So that is an understanding that we have to have. What do I do when there's no facial plate? Well, let me show you. So here we've got a hopeless tooth number 8. Number 9 doesn't look too hot either, but number 8 is our problem. So when we took out number 8, I just reached in there and I could just feel with my finger and now a probe that there's just no facial plate there. So in this situation, a lot of you guys do, routine socket grafting and things like that. This is all you do. You just socket graft it. And if you don't know how to do this, I've got webinars on it through Henry Schein, or you can take one of my courses in Vegas if you want to. But you can graft the socket and you can just come back and let it heal up. And it only takes, 12 to 16 weeks, guys. And then you can come back and place your implant and stock abutment provisional, and restore it. This is my office manager's husband, so this was a pretty important patient as well, since he's married to my office manager. So this is him at 13 years. Once again, I'm showing you guys this not to brag, but just to show you that it does not really matter, how you do it, whether you do an immediate implant or if you decide to stage your approach. As long as you follow the principles and do things the right way, you're going to get a good result. There's 3 critical moments in implant placement. One is case selection. We talked a lot about that, right? Case selection, choosing the right, phenotype, smile, design, all that. 2 is atraumatically extracting the tooth. 3 is the osteotomy preparation. So we want to make sure that we drill the hole in the right spot. Once again, if you guys want help with any hard or soft tissue grafting, I can freely say this with Henry Schein and BioHorizons Business Association. Check out our course. The next one's November 7th and 8th. It's $1,800 for two full days. You get pig jaw surgery, you get live surgery. It's a pretty good course if you guys are into hard and soft tissue grafting. But just snap a shot of this. I'm not trying to sell you guys a bunch of stuff, but atraumatic extractions are important. So one of the tools that I want to share with you here in a second is how to avoid situations like this. I mean, if you're having to like grip it and rip it and you're just tearing up, facial plates left and right, maybe immediate implants are not for you. So let's get you guys taking out teeth very predictably first. So in a situation like this, if you haven't done so already, purchase a nice, set of periotomes. And one of your sets of periotomes should contain this little corkscrew type instrument. If you've ever broken a tooth off this deep before, this is nice because you can just screw this right into that pulp chamber and get that tooth out without, messing up the adjacent soft tissue. I'm gonna skip this one. So this is one where I was taking out the tooth broke off way up into the socket. And this Benex root extractor is really nice. It's a contraption that you have to buy. It can get kind of expensive if you don't do it a lot, but I do this a lot. So this is a nice way to atraumatically extract a tooth without reflecting a flap or getting out your drill. But at any rate, you just drill, a small little post space, and you screw that the post into the post space of the incisor. Attach a wire to your Benex root extractor here. And then at the end here, you'll have a knob that all you do is you just screw that knob and it puts force on that wire so that you can get this thing out pretty atraumatically. It's pretty easy to lose a facial plate. So, one of the things that's why we preach, investing in periotomes, getting the Benex root extractor if you need to. What we know about facial plates is that 87% of them are 1 millimeter thick or less. So they're very, very delicate things. So just be sure that we focus on getting those teeth out nice and atraumatically. So I'm going to end with this canine case, and then we'll have a few minutes left over for questions. But this is a gentleman who's got a hopeless tooth number 6. And we talked about how hard teeth are to extract. So you want to be careful with immediate implant canines. You don't want this to happen to you. Okay. This is an implant that's placed too high, too facial, and we know exactly how this happens, right? Where that implant is exactly the root orientation of the canine. And that's what happened. Take out the canine. You think you're just going to put your implant in, straight into that socket. Well, guess what? Your implant's going to want to follow the path of least resistance, which is to the facial. And this is a mistake that I see all the time. So when we see a case like mine here, tooth number 6, we want to make sure that we, once again, get the tooth out atraumatically, but you got to start off with the CBCT, right? So when I look at this, I'm going, even if I break off the facial plate, my implant's going to be so far to the lingual in order to get a nice cingulum emergence. I'm still going to be in really, really good shape. Now, here's an up close view of that implant treatment plan. Now, the tip that I have here is we want to aim for the apex of your implant to engage that 3 to 5 millimeters of native bone. Okay, that's what you want so that you can have good primary stability. So here we are, the tooth is broken off at this point at the gum line, and we got to get the tooth out. Now, this is back before I had my Benix root extractor, so I had to reflect the flap. I'm not worried about it on a canine. Maybe on a front tooth, I probably wouldn't do this, but on a canine, I'm just going to reflect the flap so I can see everything. I was able to take the tooth out, but as you can see, I ended up cracking the facial plate a little bit, but we still left it intact. Now, the next thing here is the implant. Where does the implant go? It does not go here, right? That's how you end up with all the recession in the crazy long tooth. Where the implant should go is right here. Okay. Now, the problem with that is that's a slope. That's a slope of bone. So as you drill, your drill is going to want to slide into that facial space. And that's not what you want. So you got to get this burr right here. This is the 2.0 Lindemann bone cutting burr. And you'll notice on this drill, it's got really sharp teeth on the sides. So this is how you can redirect any osteotomy that you've prepared. If you don't like the position, use this drill, okay? This will move you to the left, right, front, back. It'll do whatever you want it to do. So that's how we avoid that path of least resistance with our implant. We're going to drill a new hole, and then that way we can place our implant. Once again, you got to pick an implant that's tapered with aggressive thread geometry. You want something that's got some good bite to it. And preferably nowadays, we go with platform switched implants like the new BioHorizons Tapered Pro Conical. That just gives you a little bit more primary stability for one of the implant, but also after the final delivery of your crown, you have better stability of your abutment to the implant so that things don't move around and trap bacteria and cause that crustal bone loss that we all hate. So here's our final implant placement. And you can see we got a huge gap to the facial. And if you got a gap this size, you got to graft it. So this is BioHorizons' Gen 8 blend. All this is a cortical cancellous bone. Super cheap and easy to use. Place that in there. And then in this situation, I used my healing cap to hold down the membrane. So what I do is I get my piece of membrane, I cut a small little hole or make a slit into it, and then I just screw it down. And I don't need to suture it down because my healing abutment will hold it into place. So that's what it looks like. Secure. And then at this point, just take a radiograph. If you like the advanced immediate implant stuff, I love this book by my friend George Romanos. I've read this thing cover to cover like 1,000 times. I love this book. Final restoration looks like it should. And this is with just a healing abutment placed at the time of implant placement. So with that, I've got a few closing thoughts for you. The real key to success with immediate implants is proper case selection. I cannot say that enough. Choosing the right case, the low-hanging fruit, like I like to say, that's going to be your key to success. Remember the 3-2 rule and use a guide when you're first starting out. 3-2 rule is important because I tell you, I see this all the time where people show me cases and I tell them, you didn't place it deep enough. Placing it too deep is better than not placing it deep enough. And a lot of times that's the miss, is not placing it deep enough or placing it too far to the facial. And then the most critical, of course, is if you hit another tooth, don't do that. If you do any of these things and you know that you're going to get a bad result, just take it out. It's not a big deal. If you have no other questions, I'll stick around here for questions. But if you think of something later on, just shoot me a message on Instagram. So thank you guys.
Thank you so much, Dr. Wong. That I'm not even a dentist or a prosthodontist, and I was super interested by all of your real life examples. I did have to look away during a couple videos, but other than that,
That
very
happened.
interesting. Okay, so we have a couple questions. So we will start with, do you ever add bone beneath the buccal flap to increase bone width?
Yeah, so when you add bone to the buccal bone, we call that a veneer graft, and you can do that as well. I'll do that on occasion. Usually, when you do that, it's because your bone is too thin, so it's less than that 2 millimeters of bone that you want. And in that situation, absolutely add some freeze dried bone to the facial of it, and we call that a veneer graft. Totally cool to do.
Thank you. And then also one of the requests was the last slide. They asked if you could put that back up since your screen is still showing on the bottom line, they said. So I assume,
Is it the tissue grafting course, the hard and soft tissue grafting course?
well, they said last slide on the bottom line. So I assume it's maybe the slide before that.
Ah,
But I'm sure they will let me know if not. Okay, so a couple more. What is your protocol for cleaning out the socket?
yeah. So for me, I'm just straight up hand instruments, and if something's really tenacious, like granulation tissue that's tenacious, I'll just get my high speed hand piece and usually use a round diamond, and I'll get it out that way.
Great. And then what brand was the Alloderm you used for the dual zone case?
Yeah, so for the dual zone, that for me, you can use thin out. I'm sorry, there's two different thicknesses of Alloderm. You can use regular Alloderm if you want, or if you just want something thinner. Let's just say you don't feel comfortable, tucking that thicker piece of Alloderm in. You can use BioHorizons Memlock membrane, and I use that because it stays around a long time. And I got to be frank with you, it's cheap. Yeah, compared to everything else, it's a lot less expensive.
Interesting. Okay, so one more, or more may come in. But if you did a buccal, is that how you say it? Buccal?
Buckle, buckle.
Buckle. Buckle veneer graft, would you place a collagen membrane over the bone and beneath the soft tissue? I can repeat that for you.
Yeah, you can if you want to. A lot of times I don't. I'll just place I'll place a really thick, heavy layer of that of bone graft material without a membrane. Now that's assuming that we're just talking about a veneer graft over thin bone. If you're trying to cover exposed implant or threads, then you should use a membrane.
Okay, thank you very much. And I will give you guys just one more moment if you want to throw in another question. And Dr. Wong, would you mind? I'm not sure which slide they meant, but I think maybe the slide that has all of your Vegas information might be helpful for them.
Yeah, this is great. I mean, it's not an expensive course to begin with. It's only $2,000, but yeah, I think 2 days, thanks to the Oral Reconstruction Foundation, they subsidize a lot of it. That's why we're able to do it for $1,800. It's just a good weekend too. Plus, you guys
Ve-
kind of feel my style. We can do this for 2 whole days and ask questions and really dive in a little bit deeper. So
Great. Well, we have one more. Sorry about that.
no worries.
So for veneer graft, do you like xenograft, xeno plus allo, question mark, and or auto?
Yeah, just straight up, just the easiest is just do an allograft. Don't use xenograft because here's why. With xenografts, they don't resorb, so it can also poke through the tissue over time. And patients, it kind of freaks them out when it happens like a year or two later. And on top of that, some of them can have an inflammatory response with the tissue. So just use an allograft. Okay.
Amazing. Thank you. Okay, well, I think that's all of the questions we have.